3 times a day or 4 times a day to once a day, if that would do a better job of minimizing adherence issues. Cost is a big issue in the United States. Many people don't take their medications because they can't afford them. So is there assistance that we can give them financially? Is there cheaper medications we can put them on? But they also had issues that we had with the medications that we needed to adjust them. We needed to add some therapies. We needed to increase the doses of some. We needed to discontinue other ones. And then referral. So these were all the activities that clinical pharmacists were doing in the clinic setting to begin trying to impact patients. Well, what did we find? We found out that when we put a pharmacist in the clinic, so that's the intervention group, that we had a statistically significant quicker visit than usual care, meaning just the pharmacist, the physician. And so we could demonstrate that mostly within 7 days, we were able to get a pharmacist clinic visit scheduled with the patient, and that was much quicker than the usual care or the physicians. But more interesting was what happened with readmission. And you'll notice in the right where the red stars are, is that if the patient attended the visit within either 14 days or 30 days, they had a statistically significant reduction in readmission. More fascinating is that if you look at the last two, that the pharmacist present at initial follow-up appointment was statistically significant. But if you notice just above that, if they saw the provider, the physician, that was not a statistically significant impact on readmission. So it demonstrates that if you put a clinical pharmacist into the care process in the outpatient setting, medication therapy outcomes are much better than if it's without a pharmacist. So the data is so impressive, we now schedule primarily with the pharmacist as opposed to with the physician. So for us, there's always going to be a physician in the clinic. We don't schedule on what kind of physician or which physician it is. We schedule primarily about the pharmacist because that has demonstrated a statistically significant reduction in readmission by inserting a pharmacist into the care of the patient. And that actually has been extended out after 90 days. And so if you do a Kaplan-Meier survival curve, you'll demonstrate that 90-day readmissions are reduced by a pharmacist in there, as well as a composite of both emergency department visits and readmissions by the insertion of a pharmacist into that care process. Very compelling data that has really driven the growth of pharmacists within our organization. To follow that up, again, another data set that we did is statistically significant at 1 month, 3 months, and 6 months of a pharmacist reducing ED visits, hospitalizations, as well as office visits. So one of the points I almost brought up earlier that was talking about how do I expand pharmacist role in the clinical setting? And it was clear to me that there were many people frustrated that they were unable to do that. So one of the things that we've been very successful at in our organization is researching what are the medication-related problems. Then taking that data, trying to insert a resource in there, and then analyzing the impact of it. So let's say you want to have pharmacists in the infectious diseases service to manage antimicrobials that we talked about earlier. Well, what is the problem right now with antimicrobial utilization in your organization? Do you use too much? Do you use the wrong ones? Do you use too few? Do you use too many IV medications, not oral medications? Studying and documenting what the problem is, and then asking, can we put a pharmacist in there to reduce antimicrobial utilization? We've repeated that over and over and over and again in our organization, and through that we've been able to grow and grow resources. And this is one of the models that we've been able to grow pharmacists in the ambulatory care setting. Now, I think the full package that we're now looking at is what happens when you have a pharmacist on the inpatient setting and a pharmacist on the outpatient setting, and they manage the full, complete handoff of that. And so we did a very large study. We randomized patients to 4 different arms. Inpatient pharmacist to outpatient pharmacist handoff. Inpatient pharmacist with no outpatient pharmacist. No inpatient pharmacist with outpatient pharmacist, or no pharmacist all along in that bundle of care that we were talking about. And so we did a very large study on this with about 250 in each arm. And what we demonstrated was the most significant reducer for readmissions was inpatient to outpatient pharmacist handoff. And that has been demonstrated at all the other arms to show that if you put pharmacists in the care transitions from inpatient to outpatient, or from one setting of care to another, you're able to demonstrate that you improve quality by reducing readmissions on patients. So a couple things for you to think about as I conclude my talk. One of which is, what is the need for health care within Egypt? We talked about antimicrobial stewardship. One major need right now in the U.S. is readmissions. It's too costly. Quality is not very good. But are there other opportunities that pharmacists utilizing their medication knowledge can improve quality? Once you figure out what that is, then the opportunity is to place pharmacists there and then analyze pre and post what was the impact of that change. And if you're able to demonstrate that the return on that investment is greater than what you put into it, and many times it is that a way to sell your services so that you can further integrate yourself into that organization? That's step one. How do I get clinical specialists? How do I get clinical pharmacists in my organization? But, that takes a lot of leadership. It takes challenging the system. It takes putting yourself out there saying, I can deliver, I can pull that forward. But secondarily, how do we begin training the next generation of individuals to do that? For us, we utilize residents to do many of these projects and many of these activities. So how do I begin looking and thinking about pharmacy residents? Not only is that a great way to expand services, but man, that's a fantastic way to train individuals in the model that you want to go to. And then third, after that, how do I bring pharmacy students into that? So I'm going to stop here, and I thank you for your time.